So today I'm going to take some time to talk about blindness and visual impairment. Throughout this presentation, I will go over several different topics, starting with what the difference is between blindness and visual impairment, what are their characteristics, who do they affect, and why do they occur, and finally, how they implicate educators in the field of early childhood. So what is the difference? The World Health Organization states that blindness or visual impairment can be separated into two categories: distance vision impairment and near vision impairment. If you look at the top left image, you'll find that distance vision impairment is further separated into four categories: mild, moderate, severe, and blindness. The fractions listed in each category refer to scores of visual acuity testing. The World Health Organization lists them in the metric system, as that is the globally accepted unit of measurement. But to make things a bit easier, I have listed the empirical equivalencies in red. If you refer to the bottom right image here, you'll find an example of the most commonly used tool in visual acuity testing, and it's called the Snellen chart. To take the test, patients stand at a fixed point in the room, cover one eye, read each letter and each row from top to bottom, then cover the other eye and start the process all over again. After the test, patients are given a score in the form of a fraction. The top number refers to the distance that one stands away from the test, which is 20 feet or 6 meters. In some smaller offices, physicians may use alternative charts or tools like the phoropter, which is shown here in the top right image, to account for the lack of space. To allow patients to stand exactly 20 feet away from the chart. The bottom number in the fraction refers to the distance distance that someone with normal vision would be able to read the same letters. So for example, I have 20/20 vision, which is the standard for normal vision. So if you look at the top left image, if you have a mild visual impairment at 20/60, that would mean that the smallest numbers you're able to read standing 20 feet away from the chart, I would be able to read at 60 feet. Group 2 is near vision impairment. The World Health Organization states that to be near vision impaired, your visual acuity score would need to be worse than N6 or M.08 at 40 centimeters. So what does that mean? This is measured using different charts. The N6 score is attained using an N notation chart, which is featured in the bottom left image here. The chart features a series of prompts listed in different font sizes. Each font size correlates to a score that measures one's ability to read which measures the smallest font someone is able to read at 40 centimeters away. So now with this understanding, we can view visual impairment as more of a spectrum of visual acuity. In terms of distance, 20/20 would be on the far end of the spectrum, relating to the most accurate, and blindness would be on the opposite end, relating to the least accurate. So there are two different types of visual impairments, neurological and structural. We're going to start with neurological visual impairment, or NVI, which is a visual impairment caused by an injury or disorder within the brain rather than the structure of the eye. And the medical community certainly likes its categories because it is further separated in two groups: cortical visual impairment and delayed visual maturation. So cortical visual impairment, or CVI, is a disorder caused by damage to parts of the brain that processes vision. The severity is measured across the CVI range, which starts at phase 1, being the most severe, and extends to phase 3, being the least severe. Causes vary, but the most common are lack of oxygen, often after a stroke, hydrocephalus, which is a buildup of fluid in the brain, and infections that reach the brain. So, for example, meningitis or rubella. And also certain genetic conditions can also cause it. Characteristics vary greatly with each case and depend on the type and severity of damage or functional limitations. A lot of CVI cases can be treated, which is why early detection is so important. That being said, there are a wide range of characteristics to look for when determining if a child is suffering from CVI. It's important to note that every child is different, so each case will vary. All of the characteristics that we're going to talk about are associated with CVI, but not every child needs to exhibit every symptom to be diagnosed. So children with CVI often show a preference for bright colors like red or orange. This is because the part of the brain that processes color is located deep in the back left and right parts of the brain, so it's often preserved in children with CVI. They also tend to show a need or preference for movement. Children with CVI, again, the visual cortex being located in the back left and right parts of the brain, its function is generally preserved in children with CVI. So generally, children with CVI will have difficulty processing objects or seeing objects that are either still or presented directly in the center of their visual field. Some children will even go as far as moving themselves physically to stimulate their vision. Children with CVI also tend to show a preference for familiar objects or faces. This is because they tend to have. This is because visual processing as a whole is difficult for children with CVI. So naturally, the brain is going to process visual input that it's already had a chance to process in the past. So next we have visual latency and need for simplicity. Because of the difficulty children with CVI have with visual processing, children need extended periods of time, and visually sterile environments to process visual input. Complexity and overstimulation kind of work in the similar function as like a virus to a computer, bogging up the neural pathways with too much information and slowing down the overall process. Children with CVI are also often observed gazing into lights or off into the distance for no real purpose or intent. Unfortunately, there's not a whole lot of research that points to one specific cause, but there are a couple theories out there. For example, children with CVI have a difficulty processing audio and visual input at the same time. Which leads some to believe that even though children with CVI may appear that they're just gazing for no apparent reason, they're actually just trying to focus on processing audio input. Children with CVI also tend to show a preference for a specific visual field. This is because any part of the brain that is damaged relating to one side can cause visual impairment in the corresponding visual field. So, for example, if I have damage to my right visual cortex, I will have a visual impairment in my left visual field, which would look like me seeing objects more efficiently and quickly, or more frequently, that are presented in my right visual field. Oftentimes, children with CVI appear that they are nearsighted. So, for example, you may observe a child in your class with CVI bringing objects close to their face to look at them. As I mentioned earlier, children need simple and visually sterile environments to process visual input. So the reason for this behavior could simply just be that they're bringing it closer to cancel out background clutter. Next is delayed visual maturation, which is a visual impairment in infants that generally improves by 4 to 6 months without any sort of treatment, but it can persist up to 12 months. Distinct causes are unknown, but researchers have found links between DVM and prematurity and perinatal complications. Characteristics are delayed or non-existent reflexes. So, for example, an infant would not close their eyes or show any type of response to a light being flashed in their face. Infants also appear as if they cannot see objects or faces. So this might look like an infant turning their face away or not even acknowledging a familiar face, as if they have no preference for their face, as opposed to others, as opposed to like a complete stranger. DVM is separated into 3 groups. Group 1 is isolated DVM. Children in this group generally recover quickly and experience a complete recovery. However, because of the DVM, they often experience delays in achieving developmental milestones. Group 2 refers to children with DVM and systematic disease or mental retardation. Children in this group are usually born premature with severe intercurrent illness early in life or diagnosed with mental retardation. Recovery is fairly similar to those in group 1, however, it tends to be much slower and can be less complete. Group 3 refers to children with DVM with ocular disease early in life. Some frequently experience nystagmus early in life, which is a condition that causes involuntary rapid eye movement, either up and down or side to side. Some examples of ocular disease would be albinism, bilateral cataracts, or optic nerve hypoplasia. Recovery in this group is much slower than group 1. However, it is quicker and more complete than group 2. So now we can move on to structural visual impairment, which is a visual impairment resulting from damage to any parts of the actual structure of the eye. To gain a better understanding of structural impairment, we will go over a few of the most common causes, starting with microphthalmia and anophthalmia, which are these conditions. Microphthalmia is when a baby is born with one or both eyes too small, whereas anophthalmia is when a baby is born without one or both eyes, without one or both of their eyes. That was a mouthful. Some causes are genetic mutations or abnormalities. Certain medications taken during pregnancy can lead to this. Exposure to harmful materials or substances during pregnancy. So, for example, X-ray radiation could be a cause. Symptoms vary, but can include mild to severe visual impairment. Small eye sockets can impact the structure of the small eyes, or missing eyes can impact the structure of the eye sockets, which will, as like a domino effect, affect the structure of the surrounding areas of the face. Children with these conditions may also experience other eye conditions like coloboma, cataract, or microcornea. There are a variety of treatments, starting with devices. So, for example, conformers or prosthetic eyes can be used to address structural damage. Protective eyewear like eye patches can be helpful for children who have only one affected eye. Surgery is another option, but it's not really a solution for the visual aspect of it. It's more to address the structural symptoms. Current research estimates that about 1 in every 5,200 babies are born with one of these conditions in the United States each year. Coloboma is an eye condition that people are born with, and it is when a part of the tissue that makes up the eye is missing. There are several different types of coloboma, and symptoms vary depending on the type, but can include vision loss or blindness, light sensitivity, and deformity. For an example of deformity, if you look here at this eye, you'll notice that the pupil looks kind of like a keyhole shape. That would be an example of iris coloboma. Some causes are genetic mutations or abnormalities. It can be hereditary, and some environmental factors like drinking during pregnancy. Some treatments, glasses or contacts can be helpful. Surgery can be used but it's mainly for appearance, as it can't really restore the vision. But surgery can be done to fix like this keyhole shape in the iris right here. Devices can be used if glasses or contacts fail. Eye patches or eye drops can be effective. Patches are really only effective if the patient only has coloboma in one eye. As I mentioned earlier, one of the symptoms is light sensitivity. So if a patient is experiencing that symptom, an eye patch can kind of help filter out that light. Patches and drops are both used to prevent amblyopia, which is also known as lazy eye. Pediatric cataracts. So cataracts is a cloudy area in the lens of the eye, which is responsible for focusing light and color input into the retina and the macula. So pediatric cataracts causes more visual impairments in children than any other treatable condition. Current research estimates about 5 to 20% of blindness worldwide as a result of cataracts, untreated cataracts, and an estimated 20 to 40,000 children are born with cataracts each year. Symptoms vary with each case, but some include decreased vision in the affected eye, whitening or clouding in the lens, wandering or crossed eye, light sensitivity, and nearsighted vision. Some children with cataracts display no symptoms, and this would be because they may have grown accustomed to functioning with reduced vision or learn to use the unaffected eye to function. Over here, you'll find a very long list of causes, and this list is even very condensed. So treatments, one example of a treatment is mydriasis. It's when small drops of a medical substance called epinephrine are administered to the eye to dilate the pupil. I'm sorry if I'm not pronouncing that right. The purpose of this is to expand the pupil past the affected area. It can be effective for very early cases where only a partial cataract is present, and this treatment is often preferred over surgery in patients under 4. Surgery is also an option, and I have 2 videos here. A surgeon makes a small incision into the sclera and sucks out the cloudy lens with a small suction tool. In some cases that are more severe, the patients may need an artificial lens inserted, which is shown in this video here. After the cataract is removed, a plastic lens is inserted and it's kind of smoothed out. No stitches are needed because the sclera heals very quickly. Surgical complications are very rare, but risks greatly increase in patients under 4, which is why mydriasis is generally preferred in patients under 4. Because of the smaller eye size, because children under 4 just have smaller eyes, it just makes maneuvering the parts of the eye and accessing things more difficult. Children under 4 also have their sclera is more malleable, which is where the doctor needs to make the incision to remove the cataract. Because of this malleability, more pressure is required to make the incision, which creates pressure to various surrounding structures of the eye, which are listed here. We have the intraocular contents, the vitreous body, the macula, the retina, and the optic nerve. The vitreous body is here, which is kind of like a pocket of clear gel-like fluid. The purpose of the vitreous body is to, it serves as, it kind of maintains the structure of the entire eye, but it also, the liquid inside of it also aids in filtering light and color input that passes through to the retina and the macula. So here I have a list of other common causes to structural visual impairments. I think one of the most common ones that we see in daycare settings, especially infant rooms, is blocked tear ducts here. Generally, this kind of just goes away, and a lot of people, it looks like yellow goop just kind of coming out of their eye constantly. A lot of times babies will wake up and their eyes are just like crusted shut. A lot of people tend to think that it's pink eye because a lot of cases it's only in one eye, but it's actually just a clogged tear duct. Another common cause that is really common is unfortunately retinoblastoma, which is eye cancer. So we just learned a whole lot of information about visual blindness and visual impairment. But what does that mean for us? Well, that basically means that we have a lot to take into consideration when developing educational environments and curriculum. So starting with the structure, structure and lighting. We discussed in a lot of cases, children with visual impairment have light sensitivity. So one might consider using curtains or blinds to reduce the light irritation. Some children with light sensitivity may be sensitive to the hue or tint of commercial lighting, so you could possibly bring in alternative lighting to help that. Non-reflective surfaces could help prevent glare from overhead lighting. Um, Another thing is seating. So you want to seat children with vision impairments closer to things if that's a symptom of if their visual impairment prevents them from seeing things far away, you want to seat them closer to things to make it easier for them to see the teacher or the whiteboard, whatever it is that you're using to do your lessons. Excuse me. Um, oh, and another thing, it's being mindful of how um, again, being mindful of how windows impact children either negatively or positively. For children who, for children with light sensitivity, windows might be a distraction, so consider seating them with their backs facing the window. Other children with light sensitivity to commercial lighting might benefit from natural lighting more, so maybe consider seating them closer to the window. Another thing to consider when developing the structure of your room is keeping your walkways open and clear of any obstacles to make sure the space is safe for people. Another thing to consider is organization. You want to designate specific places for toys and materials that remain consistent and make sense with the flow of the room. When making labels, use carefully when making labels, use carefully selected visuals and along with the printed word. So, for example, children with CVI, we talked about earlier, tend to show a preference for familiar objects and faces. So, one thing to consider when making labels is choosing visual representations that they've already had a chance to process and are familiar with. Learning center designs should also be designed with visual impairment in mind. For example, children with CVI a child with CVI who has difficulty processing visual and audio input at the same time might benefit from some modifications to the reading corner. One could consider putting a 2-person limit at the reading corner to reduce audio clutter and help them focus on reading. Another thing to consider would be to put a canopy or tent in the reading corner to reduce visual clutter in the environment. Teachers also need to adjust their practices. Plan appropriate transitions and timeframes for lessons and activities so every child can participate and engage. As mentioned earlier, children with CVI need more time and less distractions to process visual input. That being said, they may miss visual cues on schedules or may not hear a teacher say it's time to clean up due to the amount of stimulation in the room. Plan for these occurrences with longer transitions and take careful note of what works so you can refine your routine each day. Also, give yourself enough time to plan. It may take a bit longer to plan lessons for a group with some visually impaired children, so make sure you have enough time to set aside and really consider everything you have planned to make sure it's fully inclusive for everyone in the room. Which brings me to appropriate lesson plans. Plan activities and lessons that are appropriate for all children with or without visual impairments. For instance, a child with coloboma for a child with coloboma in one eye, you might plan an activity where children have to look through a microscope for whatever reason. You only need one eye to look through the microscope, and everyone would only be using the one eye. This type of activity would allow for the child to participate in the same way as everyone else. It may be unrealistic to plan every single activity this way, but for the ones that aren't, the ones that you can't, just make sure that there's built-in modifications. Many of us have learned all the ways that activities can be modified to meet the various unique needs of each child within the group. Another thing is to be knowledgeable about resources. So know about assistive devices, technology, or other learning aids that could benefit children with visual impairments. Some may benefit from using magnifiers for reading, while others may benefit from using from large printed text. Whereas others may benefit from speak text or audiobooks. There are a bunch of different resources out there that can help us provide the most engaging and inclusive environment. The first step is just being open and aware of them. Another thing is to plan for missed content. Again, it's important to plan ahead of time and have a variety of ways to learn one topic. Each child learns differently with different struggles and strengths. So, giving many different opportunities will increase the likelihood of a meaningful learning experience. Much like the, sorry, wrong part. Talk about and celebrate differences. So carefully choose books, movies, or videos with visually impaired characters, and try your best to choose ones that portray them as strong, independent, and capable to build their confidence up and encourage tolerance within the entire group. Again, the type of lesson plans and activities you choose that are fully inclusive without modifications will be a great way to celebrate differences. They they'll unite everyone in the class with a common goal that everyone can work towards regardless of their differences. Partnerships is huge. Our partnerships are huge. Resources and information. So educate yourself on visual impairments. Keep information about development, activities, alternative practices on hand and available for families. And consider all the different places that you could store this information so that families have multiple opportunities to take them. Also, make yourself available to the best of your ability to be there for families. If they confide in you, offer your support to strengthen their trust in you, their confidence in themselves, and make them feel less alone. Research parent support groups for families of children with visual impairment to connect them with others that share others in the community that share their experiences. Engagement is another area that's implicated by this. Plan opportunities for families to meet and engage with other families. Make sure the opportunities suit the needs of their child's visual impairment without singling them out. For example, you might plan an event for families to come that's a sensory workshop. You could do things like making slime or Play-Doh or playing with Orbeez. Another thing could be like a taste testing game. I saw on Pinterest on a sensory memory game or a texture memory game. It was super cool actually. It worked very similar as a standard visual or a standard memory game, only instead of remembering like the pictures of the cards, each card had some sort of texture to it, and you had to remember the feeling of it to remember where it was. Lastly, another hugely important part is consistent observations and data collections. Maintain consistent record of observable behaviors, progress, or changes to share with families and care providers. As we mentioned earlier, several points throughout this presentation, there are many types of visual impairments that can be treated but it's dependent on how early it's detected. So any and all information that we collect and share could be helpful could potentially help families and caregivers make accurate decisions about treatment or appropriate intervention services. The information we learned today was a lot, but it will help us understand each child a little bit better and help us in our ability to provide all children with a learning environment that they deserve.